think we can start. First of all, I would like to apologize because Javier is not here today. You'll try to connect later. He is in with a patient, so probably in a few minutes he will be connected. On the other hand, I would like to present to you today Dr. Paolo. He is one of the pillars of the SELNET project of our pathology network, and also one of the greatest pathologists in sarcoma that we have nowadays. And I hope everyone enjoys this talk today, and I'll give the word to Dr. Paolo. Thank you.
Thank you, David. Thank you for your nice introduction. I mean, you know, I will just try to share with you some expertise that came through, you know, basically based on my experience in looking at a certain number of cases. I mean, I always remember people. I'm sure that Andrew will have the same opinion. But one day Crisoni told me, you know, when I was very young, and asking me, how God are you so good? I said, look, I mean, we saw so many cases. I mean, if you don't get good, it means that simply you're not really clever, isn't it? So the baseline is that I have to thank all the people. First of all the people who taught me soft tissue pathology in the past, and certainly Chris Fletcher, Tony Nascimento, Andrew Rosenberg, and Crisoni, all these people who really have great expertise and huge generosity in sharing ideas. But also all the people that through the years share with me cases. And you know, when fellows come to my place to look at the cases, I always ask them, it's better you start from the most recent years, because you know the chances that you get good diagnosis far higher than when you get back 30, 35 years. And what I'm trying to share with you is just some ideas that came over, showing two cases and pointing to some of the most critical areas in which we may make mistakes. And the baseline is that, of course, we all know we are dealing with a very heterogeneous group of rare malignancies. So I don't want to offend anybody, but you know, if you do colon cancer, for example, of course, some colon cancers can be extremely difficult, and some cases actually are really challenging. Some variants are difficult to interpret and so on. But basically, you're dealing most of the time with a few limited number of things. Then, of course, you have to implement many other stuff, like, of course, microsatellite instability, immunohistochemistry, and so on. So it becomes, honestly, quite challenging. But in the field of mesenchymal neoplasm, we definitely face one issue, which is rarity. And the combination of rarity and heterogeneity affect diagnostic accuracy. So my experience comes from approximately 70,000 cases of second opinion I accumulated through the last 25, 30 years. And so I will just try to share with you what comes from this type of experience. So one of the issues when you're dealing with rare cancers, which is rarity, and you know we have a definition of the 6 cases per 100,000 people per year. And wherever you go, diagnosis and treatment is a challenge. Diagnosis has its own challenges, treatment has its own challenges, but as pathologists, we need to take the responsibility to guide the type of treatment. So I still believe that even in the era, you know, of the molecular, of the explosion of molecular techniques, which I'm very fond of, as you may know, actually morphologic microscopic observation remains the mainstay for proper treatment. Now, you know, I will just share with you one thing. Wherever you go, between 30–40% of the cases diagnosed in non-expert centers, let's say, are diagnosed inaccurately. But this should not lead to say, all right, pathologists are not competent. the issue is totally different. The problem is, how can you become competent if you don't see enough cases, if you didn't train in an expert center? That is one of the main issues. So we should stop using the so-called blame and shame attitude. We shouldn't blame people because they do not make good diagnoses when dealing with mesenchymal tumors. We should simply ask ourselves what we did put in place in order to allow them to do a proper job. This is the main question. And many situations, we didn't do anything to help people for doing good things, good diagnosis. You know, in the end, even educational activity, I've been involved in millions of educational activities. When you go back in your place, you don't have access to to a good number of cases, then of course you lack reinforcement, then you are at the risk of regressing to your previous uncertainties. That's why maybe also networks of educational networks, diagnostic networks are really helpful, which is in the end what we are trying to do within this SELNET project. So as I mentioned to you, whenever you go, you have this kind of 1/3 of cases diagnosed not perfectly, but you may be surprised when dealing with clinical trials. Let's pick up EOTC, and you will see that even there, when you have, in a way, expert centers, we get into a range of 7 to 10% diagnostic inaccuracy, which raises a point. I mean, some centers are expert centers from the clinical standpoint, but they didn't pay much attention in organizing the diagnostic settings, which is one of the issues, for example, we have currently here in Europe. So definitely there is shortage of pathologists who wants to involve themselves with soft tissue and bone sarcomas, which in bone is even worse for some reasons. So the reason to have good pathology diagnosis is because this is the rationale of any clinical decisions. Well, not only diagnosis, but also prognosis, prediction of response. Just think of GIST, for example. And always remember that whatever the sophistication of your molecular genetics, and now we all live now in an era where, in particular, our good friends, medical oncologists, think that without molecular genetics, we can go anywhere. And this is profoundly wrong, because conventional morphology is still a powerful tool. Just you need to know conventional morphology. So I will start just showing you examples of things that are so, heterogeneous that of course they can lead to some kind of challenge. So in soft tissue sarcomas, we have benign lesions that get frequently mistaken for sarcomas, not because people is ignorant, but just because the morphology tend to deviate from common criteria of malignancy that would be perfectly good for epithelial cancer, but they're not good at all for mesenchymal neoplasm. I would just mention nodular fasciitis and then go through some variants of reactive or pseudosarcomatous proliferation. I will mention probably cellular granoma and also what has been called variably pseudosarcomatous proliferation in urinary bladder. But I will start with history. All the histories are just case of mine in which we had some kind of interaction with patients. And this is a 42-year-old male who came, who had a 1.2 centimeters mass in the orbit. And on this, they made a diagnosis of spindle cell sarcoma with myogenic differentiations. So basically, he wrote me a letter, sending me the case, saying, all right, do you think I should get my radical surgery? Or maybe somebody suggested to use a radiotherapy just to kill my eye and my tumor that I have in the eye, the orbit. And this is the lesion. As you can see, it is hypercellular. And of course, we are now among experts here. So we know that this hypercellularity, which lacks significant atypia, corresponds to what we know as nodular fasciitis. But this happens every day. And basically, the thing that make non-expert people bothering is the rich cellularity, the rapid growth, the high mitotic activity. So these three conditions, both clinical and morphological, in the context of epithelial cancer would often equal T malignancy. But actually, here is the opposite. The rapid growth typically would be a young man with a lesion growing rapidly in his forearm. And then you get this richly cellular lesion with many, many mitoses. All things fits perfectly with the diagnosis of what is a pseudosarcomatous proliferation. Okay, we know probably it is neoplastic because we have the USP6 clonal rearrangement. But actually, we also know that these lesions have a sublimited clinical course. So basically, you don't need to do anything on a nodular fasciitis. And I'm just sharing with you some of the conventional morphology, extravasated red blood cells, these cellular variations, this morphology that somewhat recall cell cultures, fibroblasts in cell culture. And of course, in this context, paradoxically, high mitotic activity is more helpful than a problem. So you don't get scared because you see many mitoses. And again, the extravasated RBC. And sometimes, you know, as we, another issue that we have in mesenchymal tumor, changes like stroma can occur in any type of mesenchymal neoplasm, including myxoid nodular fasciitis. But as you know, we have mixed variants of everything, basically, the FSP, SFT, and so on. So here, when you have a change in the background, you need to be very good in somewhat scotomizing the specific feature of myxoid change and consider what is the context. You won't believe me how often we get in my consultation practice the case of myxoid liposarcoma diagnosed in the hand and neck of middle-aged males. And you know by heart, all those cases are represented by spindle cell lipoma with myxoid change of the stroma. So we need to be ready for some variation in the morphology. And even nodular fasciitis, if you excise nodular fasciitis at the end of his life, will be like a keloid type of proliferation because the tumor is just ending, dying by himself. Immunohistochemistry is not really helpful, with the exception of proving so-called myofibroblastic differentiation, so smooth muscle actin will be positive. Desmin is most of the time negative. You can pick up really few cells, or exceptional cases like those reported by Mark Mietinen, in which you may have very, very exceptionally desmin positivity. But if you do have desmin, start thinking something different. So, one important thing, if your nodular fasciitis is recurrent, then you should go back to the original diagnosis, or if you get sent a case of recurrent nodular fasciitis, 99.99% of the time, it means it is not a nodular fasciitis. So you need to start thinking about different disease. As I mentioned to you, we have the USP6 fusion. In reality, we don't do much of genetics on nodular fasciitis, with some exceptions. I can share with you the story of a week ago. So we got these young men with a 4 centimeters lesion in the oral cavity who serrated the mucosa, and that was called, probably because of the anatomic sign, which is so typical, low-grade myofibroblastic sarcoma. And you know, you look at the cases, the morphology was not typical, certainly was hypercellular. The mucosa was ulcerated, so you have a lot of granulation tissue. And then I start thinking, all right, maybe this a very crazy place for a nodular fasciitis. And this is one of the cases in which we decided to run USP6 molecular analysis, finding the classic MYH9 US-specific fusion. And this is one of the situations in which, crazy clinical presentation, diagnosis of malignancy, then we are going to change dramatically the therapeutic strategy. Then maybe you want to be sure and confirm that molecularly. So when to doubt, when NOF recurs, and also when cytologic atypia. Nodular fasciitis can be hypercellular, but can be atypical. This is not happens usually, most of the time. Cranial fasciitis is just a nodular fasciitis occurring in the bone of the skull. And I will cut the story short. Of course, when you have a baby with a lesion like that, just protruding into the brain, first of all, you have the parents of the baby quite scared and irritable, and also clinician can be a little bit irritable. But this is just identical to what we have seen. You can have a modest recurrence rate just because, here, when you have decided it is benign, resection tend to be very, very limited because of the anatomic locations. But the morphology is exactly the same. Then we have other entities which are called fasciitis, but in which you have distinctive morphology from nodular fasciitis. One of these is proliferative fasciitis. You see, patient tend to be more adult, no sex predilation, again extremities, again rapid growth, sometimes history of trauma, which is always difficult to discuss here. This is the microscopy of proliferative fasciitis. And you can see here, this is a lesion which is infiltrating the fat. And from here you can say, okay, there are sarcomas that rarely have a pattern of infiltration. Just think of DFSP, dermatofibrosarcoma protuberans. But as a general rule, with many, many exceptions, malignant mesenchymal neoplasm tend to grow more in expansive way, more than being infiltrative. So the first thing that you have to think. And then, of course, what is interesting of this entity, in addition to the myofibroblast, you have this type of modified fibroblast that somewhat resembles ganglion cells. So they are ganglion-like fibroblasts. They don't express smooth muscle markers, basically only vimentin, but I mean, nobody really today is using vimentin anymore. And just to show one case, what happens is a 51-year-old female, 2.2 centimeter mass in the thoracic wall, and the diagnosis was rhabdomyosarcoma NOS. And this is why sometimes proliferative fasciitis can be quite hypercellular, and nuclei can show some atypia. But if you pay attention, the nucleus, the chromatin, is basically non-existent. It's very vesicular nuclei, the big nucleoli, but you don't have the condensation of the chromatin that you have usually in malignancies. Of course, this is proliferative myositis. Of course, people didn't pay much attention to the fact that this tumor specifically didn't have neither desmin and neither focal myogenic. If it has to be a rhabdomyosarcoma, could it be a pleomorphic rhabdo? Myogenic would be very limited to few cells, but you would find desmin positivity plus focal, maybe 5% of the cells myogenic. But people tend to ignore when they get scared. So you see the clinical features that we have already mentioned, in particular rapid painless growth. And this is microscopy of proliferative myositis, which is very simple. You take a proliferative fasciitis, you put within the muscle, you get this classic checkboard appearance. You can see exactly the same cell population, running through the relatively preserved muscle fibers, and then you know by heart this is going to be proliferative myositis. When you have any type of malignancy getting through the muscle doesn't get so somewhat respected from the cell proliferation. You can see this is exactly the same cells we discussed in proliferative fasciitis. You can have some mitotic figures, not many, but this is possible because this is a lesion that in a way is growing up rapidly. And this is just to show you. I admit some of the cells in non-expert, non-exercised eyes would be scary. For some people, it could be terrifying, but this is a complete, totally benign entity. Okay, so what is the key points in proliferative myositis? Sarcomas, and also for proliferative fasciitis. Sarcomas only exceptionally are infiltrative. If infiltrative, let's say, for example, low-grade myofibroblastic sarcoma that we mentioned before, massive fibers are not respected. They just suffer from these things growing in between them. Another example of potential problems, this is just to tell how clinical history is always relevant. I remember once training in dermatopathology with one of the giant, actually, but a bit peculiar, like Bernie Ackerman. He always told me, you know, you have to ignore clinical history because this is a bias. I think Bernie Ackerman was a gigantic, fantastic dermatopathology, but this idea of ignoring clinical information is just an amazing mistake. I would say just bullshit, basically. Because we all live knowing and collecting all the possible information. So, for example, when I have to decide to go out and bring an umbrella, first I will check how the sky is, whether it's raining. I don't simply carry an umbrella or don't carry an umbrella independent from the condition of the weather. So I always want to know a very precise, if possible, clinical history. So this poor female elderly patient have a 12-centimeter poorly circumscribed mass in the left buttock, and they decided to call this sarcoma NOS. We didn't have the information that the patient was bedridden. And people get scared because they start, okay, there is some neoplastic cells here, there is necrosis, which is not really necrosis, it's a fibrinode degeneration of the stroma. And this, of course, corresponds to what has been also called the cubital atypical fibroplasia, because it is allotypia. Actually, are exactly the same cells you see in proliferative fasciitis and proliferative myositis, but also you have the tissue damage of the pressure, or the local pressure. And most of the patients actually are elderly, debilitated, often immobilized, bedridden, and the typical situation would be lesion occurring on the bony prominences, shoulder, hip, sacrum. But be careful. Also, young patient has been reported to have, for example, remember one recent case in which it was a girl of 16 years old with a mass. She was a little bit, you know, not obese, but a little bit with some fat. And she had this lesion in the armpit, and just was the local pressure. She developed a ischemic fasciitis in the armpit. So it may happen also in young patients. But again, you see, it is a combination of the tissue damage which is being produced by the local pressure and the morphology of a proliferative fasciitis. So the term ischemic fasciitis is pretty good, even if there are few very rare cases in which you can't prove local pressure. So in the end, it can happen even in a context of a clinical history which is not perfect. But those are the exceptions, not the rule. And this is actually the series that Bernard Legal, that is now back in Austria, and Christopher for many years actually, and Chris Fletcher put together, in which you can see some of these patients, 31, for example, and is another 32, 36. So not only elderly patients. So you need to be a little bit open-minded. No local recurrences, of course, no metastasis, because it's a totally benign condition that, of course, tend to heal when the patients are properly treated because of their actual condition. Another case, 21 years old female, 3.2 centimeter mass in the abdominal wall, biopsy, spindle cell sarcoma, Second opinion was my second opinion, nodal fasciitis. Oh, it's interesting because they didn't believe me. So when they operated the poor thing, the frozen section, they call it sarcoma. And for some, sometimes life is really crazy. The day they did the diagnosis of sarcoma, I was actually visiting that specific hospital. So they showed me the case. Look, I mean, I don't think it's a sarcoma. Just please do not do anything too wide a surgery to the abdomen. But look at the morphology, look at the radiology. Anybody now could recognize here this lesion in the abdominal wall of the patients with this, signal around here. This is bone. Of course, this is the surgical specimen, and this is what it is. This is myositis ossificans. And why it is myositis ossificans? Because you can see at even low power the perfect zonation phenomenon. So here the magic word is zonation. You have mature bud of the periphery, then you have, immature bone in the inner layer, and then you have at the very center of the lesion something which we call very closely nodular fasciitis. So myositis ossificans, also called heterotopic ossification, there could be many places, is benign, bone forming, probably no neoplastics or reactive, but this is always a matter of philosophy more than a reality. Solitary and well circumscribed. It can occur in the skeletal muscle, in the fascia, in the adipose tissue. It can be associated to trauma, of course. That's why people think it could be like a reactive post-traumatic lesions. And typically you have a history of injury, and then in 2 or 3 weeks, the patient will develop a circumscribed mass that becomes firm and soft in 4 or 6 weeks and then start calcifying. And you can see this could even be a no-touch lesions, in the sense that unless the patients suffer from pain or some kind of inability, well, maybe you may even leave these lesions behind. And this is examples of myositis ossificans in which you see very early, not much bone, maybe just a small ring here. And you start here. At a later stage, of course, is another patient. You can see more bone on the periphery. And then in the end, if you let them grow, you have this nice shell bone like an egg. And again, you can see here the zonation, very fleshy inside, immature bone, mature bone at the periphery. Myositis ossificans, a beautiful lesion. And these are the difficult aspects with the bone of the periphery, with the immature bone here, and that you get through, and then you see the nodular fasciitis like at the very center of the lesion, identical to a full-blown nodular fasciitis. One of the problems here is with malignant transformation. I'm not a big fan of this concept. I have the tendency to believe that what has been called malignant transformation in myositis ossificans, and my friends at Mayo Clinic gave me a couple of examples here. They actually represent extraskeletal osteosarcoma. But of course, anything can happen in nature. So I don't deny that this is maybe possible. But in reality, these may represent extraskeletal osteosarcoma that, of course, have the morphology of extraskeletal osteosarcoma. Can be, of course, osteoblastic, chondroblastic, round cell, even some very rarely low grade. And the patient tend to be adults, of course, it's very rare. They may be radiation induced. And you see many of these patients actually, because the tumor is so aggressive, presents with distant metastasis in the lungs at onset. And so this is really something challenging from the clinical standpoint. But you see, this is not the radiology of a myositis ossificans, of course. And again, other example of extraskeletal osteosarcoma and the typical morphology, you can see neoplastic cells producing malignant cells producing osteoid, which equal, of course, osteosarcoma. This is one of the examples of the round cell osteosarcoma and so on. So in myositis ossificans, radiology is extremely informative. I'm not saying this is a no-touch lesion because sometimes you have to resect them. But anyway, now we need to know that the magic word is the zonation or zoning phenomenon. As in nodular fasciitis, nuclear atypia tends not to occur. For me, nuclear atypia means basically nuclear hyperchromasia. This is what I usually tend to share with my colleagues when a definition of atypia in mesenchymal neoplasia. Another thing that may enter the differential diagnosis with myositis ossificans, of course, is ossifying fibromyalgia tumor, which is a thing which is extremely rare. The WHO regard this as intermediate risk of malignancy, which means rapidly metastasizing, because some of the patient actually can have an aggressive clinical course. You can see they're adult, and most often they tend to occur in the subcutaneous or around muscular masses, around the muscles. Extremities, head and neck region, and the abdominal wall, the trunk is a good place, basically anywhere. So you don't have most of the time in the limbs. Criteria for malignancy not really well defined, with some attempt which has been made basically to Andrew Thorpe and other friends. So just go, and in fact, Andrew and Sharon, in a way, they try to separate OFMT in typical, atypical, and malignant, basically based on cytologic criteria and mitotic rate, which is something you can use in your clinical practice. But of course, the lesion is so rare that it's not easy to validate in a really big series. 70 is a huge series considered, if you can consider the rarity of the lesion. And this is the morphology, which is typical. You can see the lobular architecture of the entity. You can see this alternation of spindle cells which lie in a collagenous matrix, and the other one just sitting in the myxoid bits. So that's why ossifying fibromyxoid tumor. And this is now the case in which you can see a more distinctive oval proliferation of neoplastic with oval nuclei. You can see again the collagen in between the clusters of cells, and you can see here the peripheral shell bone. Sometimes it's very well formed, sometimes it's poorly formed, sometimes it's absent. So I know it sounds crazy, but there exists non-ossifying variant of ossifying fibromyxoid tumor, which I understand is quite stupid to say, but this usually have a tendency to lead clinician to believe they would need a new pathologist. But anyway, OFMT, sometimes ossification is within the center of the lesion. When this happens, it is one possibility that this belongs to the small group of more aggressive variants. And then, of course, if you have much necrosis, you have much atypia. All this, by the way, are molecularly confirmed OFMTs. Immunohistochemistry, 50% S100, 50% desmin in various combinations. So OFMT follow the rule of 50% when immunohistochemistry get into discussion. And PHF1 gene can be rearranged, but as you know, PHF1 gene can be arranged in many other things, for example, endometrial stroma sarcoma. So it is not pathognomonic, but in contrast with morphology and anatomic location is extremely helpful. And this is what you can do by FACE. This is one of our cases in which we could demonstrate, of course, the separation of the signal. So OFMT, it's something that you need to have in your mind when discussing, of course, myositis ossificans. Then another possibility for this patient, 51 years old female, 11 centimeter purely circumscribed mass on the left thigh. Diagnosis, sarcoma. Actually, it was called well-differentiated liposarcoma. The missing information, the patient was morbidly obese. What is the story? Of course, this is a story of massive localized lymphedema, which means, okay, it means this kind of things. Because of the local lymphedema related to obesity, you have that the subcutaneous fat get circumscribed to this thick fibrous septa. It's like, let me use this term, a cirrhosis of the fat. So what you have here, you have the big fibrous septa, you have this, peculiar fat proliferation in which you have some variation in size and shape, as you may think you have in well-differentiated liposarcoma. But what is missing? Not the lipoblast, that we don't care in well-differentiated liposarcoma. You don't have nuclear atypia, either in stromal cells, which is almost easy to pick up, or in the adipocytes. So if you don't have nuclear atypia, no diagnosis of well-differentiated liposarcoma. Of course, if you have this morphology, plus clinician so nice to give you the information, and then, of course, you get into some, you get in the right direction. Oh, John Trent, I've seen myositis ossificans mixed diagnosed as osteoblastic osteosarcoma. I was very delighted to inform him of the change in diagnosis to a benign tumor. Thank you, sarcoma pathologist. So thank you, John. He's very right. I must share with you that also, us as a pathologist we can do miracle. We can do miracle. Of course, we can do miracle. Then, if we have time, I will tell you a nice story about me and Paolo Casali about how we can do miracles. And this is what you have in the adipocytes. Of course, you have, the compression of the fat. And when you have this variation in size, it's just because you have fat necrosis. And also now I will share with you another potential problems. MDM2 get expressed by histiocytes. So many times people don't know their clinical history. They don't care so much about nuclear atypia, and they pick up here MDM2. So SNAP, well-diff lipo, or typical epidermolysis tumor if you are in the thigh, and then it is not good. Because well-differentiated atypical liposarcoma, you can have, of course, this type of variation, but also you can hear this hyperchromatic nuclei. Look at here. This is what I mean for nuclear atypia. This is what I want to see before launching myself on a diagnosis of malignancy. Another case history. 47-year-old male, 5 centimeter mass in the stomach, diagnosis wild-type GIST. So we move to something more sophisticated. I just wanted to share with you some situation in which to get perfect clinical information or not to get good clinical information may make a lot of difference, particularly when you are not an expert. So that's why I would say, please don't blame your colleagues. This can happen. This can happen in particular if you don't, significant exposure. And look at this. Isn't this the perfect case? This is a mass in the stomach with a, umbilical ulceration of the mucosa. By the way, even if this case were a GIST, this would be a little bit overtreated. You may limit resection to less stomach. But then, of course, all my colleagues and friends here know that when you have this nice hyalinization of the blood vessels in a cellular spindle proliferation in the GI tract, of course you may consider GIST, but please consider schwannoma. Schwannoma, the GI tract, have a tendency to lack the combination of antigen B, antigen A pattern, but this is a perfect clue. And this is the cellular schwannoma. And many of us may remember one of the giants of our discipline, our field, which is James Woodruff, nice man, amazing pathologist, a god of peripheral nerve tumor, and a nice man. Because when he says cellular schwannoma, a variety of schwannoma, sometimes mistaken for a malignant tumor, then you read the paper and you will see that 1/3 of the cases were actually diagnosed as cellular schwannoma. And what Woodruff reported is actually a problem because, again, because of cellularity. So you don't get use, you have some mitotic activity, and if you think of schwannoma, you think of something, you may even have pleomorphism, myxoid degenerations, and so on. But here you have a purely cellular, quite monomorph cell population. And then, of course, sometimes you can have a little bit of nucleotipia, but it's very rare. And then, of course, you have the hyalinization. And most importantly, you get diffuse immunopositivity for HAS100. This would save the day. So, as most of these cases actually, when get diagnosed as MPNST. So, first of all, MPNST never, I mean, almost never, never say never in pathology, but almost never get diffuse HAS100 immunopositivity. Here, when dealing with MPNST, we have the rule of 30%. 30%, only 30% of MPNST, maybe less, will show immunopositivity for HAS100. And when they show immunopositivity, this would be 30% of the cells. If you have a lesion, a spindle cell lesion, which is entirely HAS100 immunopositive, think of cellular schwannoma, or of course, in the right anatomical location, in the right context, think of spindle cell melanoma or sarcomatous melanoma. Don't blame MPNST. This is a good rule. What about pleomorphic neoplasm with not so aggressive clinical behaviors? We need to be a little bit careful how you phrase things. I think of basically 4 conditions: atypical fibroxanthoma, cutaneous leiomyosarcoma, pleomorphic hyalinizing angiotactic tumor, and mixed inflammatory fibroblastic sarcoma. What is a typical fibroxanthoma? It's something really horrible that grows very rapidly on the forehead of elderly patients. This is what you see. But what you can see, because the patient is elderly and because the lesion always occurs in sun-exposed skin, you will see a lot of sun damage here, elastotic degeneration of the dermis. This has to be part. The second thing that you have to consider when dealing with a typical fibroxanthoma is that you should have smooth borders, not infiltrating down beyond the skin and nexa. If you look at the tumor, it looks really, really horrible, but I can promise you none of these patients will die of their disease, whatever ugly the tumor looks like. This is another example. But you can see here even some colorate and the nice, smooth contour at the very bottom of the lesions. Solar elastotic sun damage, elastotic damage, horrible disease just here. And of course, I was a baby when we first reported that P53 is mutated in a typical fibroxanthoma, in a way supporting which is a malignancy, but for some reason we don't know. His potential of systemic spread is basically ridiculously low. And the issue here is that the differential diagnosis is quite challenging. In particular, with 2 things. One is melanoma, and the other is spindle cell carcinoma. That's why you need to run a little bit of immuno in order to be sure you are dealing with a typical fibroxanthoma. I'm not so worried about leiomyosarcoma, because when leiomyosarcoma occurs as a primarily dermal lesion, again, the metastatic rate is 0%. If you go into the subcutaneous fat, they will become 5%. Leiomyosarcoma is one of the crazy tumors in which anatomic location makes the difference in terms of clinical outcome. But in the setting of a purely dermal lesion, this is not a problem. This is, of course, is a problem if I miss this diagnosis. Look at this. Doesn't it look like a nice atypical fibroxanthoma? But it's not. This is melanoma. It's a common melanoma, a melanotic. And this is spindle cell carcinoma. But of course, you can get also some atypia and then a keratin. Well, when the lesions are ulcerated, you may not see the junctional component. You may not see the real atypia in the squamous epithelium. So you need to be flexible. If you want to be a good pathologist, you need to be flexible. They consider also the possible variation in terms of clinical presentation, microscopic presentation, and so on. So remember, spindle cell melanoma, often HB45 negative, and also BRAF can be negative in sarcomatic melanoma. Remember also spindle cell carcinoma can be quite only focally creatine positive, so you have to play a little bit with immuno in order to be careful on what you have. One of the issues is, we have a patient, Francis Honicek, of course. Hi, ciao, Francis. He had a patient with a subcutaneous small leiomyosarcoma, developed mets and die. Of course, this is possible. But that was subcutaneous, not purely dermal, I hope.
Yeah.
Really? Good.
Well,
but that's, yeah.
It was one at MGH.
Oh, good. You know, at MGH happens things that you won't believe, of course. But I mean, I agree with you. If leiomyosarcoma is confined to the dermis, that is one thing. When it starts growing down, that becomes a problem. Also, it is just parenthetically for my colleagues and for clinicians, in particular, when you have leiomyosarcoma in the skin of the scalp, for reason I can't explain to you, this is a perfect place for metastatic leiomyosarcoma, for soft tissue and visceral leiomyosarcoma. So the suggestion I would give to my colleagues is, if you have a leiomyosarcoma in the scalp, please check with the clinician that the patient doesn't get any bigger mass somewhere in his body. So just a couple of points on pleomorphic dermal sarcoma, because again, when you have these type of neoplasm and you have necrosis, perineural invasion or vascular invasion, then I would avoid using the term fibroxanthoma, typical fibroxanthoma, because you can see here the local recurrence will be 28%, distal metastasis 10%. Still, no disease-related mortality. It is probably a type of time-dependent phenomenon. This is nice work from my good friends Thomas Brenn and Thomas Menzer. And you can see here, if you look at the profile between atypical fibroxanthoma and pleomorphic dermal sarcoma, they are not really different. But of course, there is probably a different clinical evolution, something subtle, that in a way keep them an indolent disease. But of course, the size of the lesion, the infiltrative pattern may, in a way, is related to a more locally aggressive clinical behavior. So what I don't accept as feature for a typical fibroxanthoma is necrosis, vascular invasion, perineural invasion, and extension, deep extension in subcutaneous fat. Then I prefer to use the term pleomorphic dermal sarcoma, always with the caveat that probably local surgery is the way to control the disease. The question is, and this is just a nice clue, can AFX occur in young patients? No. Those cases are always in the lower limbs, almost often not on some damaged skin. They are example of a typical fibrous histiocytoma. And this is a typical benign fibrous histiocytoma. If you have in your skin, it doesn't look good at all, but it's benign. And so-called atypical pseudosarcomatous fibrous histiocytoma are very rare. You know, there is one issue which you should know. 1 out of a million of dermatofibroma will go to the lungs, out of 1 million. So you don't need to write in your report, okay, now you have a dermatofibroma, which is the commonest thing we see every day, but you have a little risk of metastasis. This is not true. But in this 2% of cutaneous FH are those that may somewhat have an higher risk, but still the risk is minimal. So a typical fibrous histiocytoma needs to be regarded as a benign entity. It gets some higher risk of local recurrence, more or less like happens in cellular benign fibrous histiocytoma or an aneurysmal benign fibrous histiocytoma. So we don't need to, you know, jump on this poor patient just because they get some crazy nuclei within the lesion that otherwise look typically as a dermatofibroma, including foam cells. This is one, I admit, quite extreme example of a typical FH, but you know, this is something acceptable, and this is nice, crazy mitosis. And as Chris Fletcher says, these tumor cells are so incompetent that they even can develop a proper mitosis. This is just a way to, of course, to make fun of this tumor. What about PHAT then? This is, you know, quite challenging. This is extremely rare. Typical occurrence in the subcutis of the lower limb or the lower limbs with a broad age range. And basically the name, which was put together by Sharon Weiss, is that of thin-walled ectotic vessels with perivascular hyaline material plus pleomorphic cells. Basically no mitotic activity. And this is the lesion. You can see the perfect combination of angiectatic hyalinized blood vessels plus pleomorphic cells. So it fits perfectly. This is just high power of the lesion. This is another lesion. Why we don't want to see mitotic activity? Because in the experience that we accumulated among many colleagues, when you do have some mitotic activity, you need to be careful because you can have PHAT-like features in high-grade sarcomas. So it's better that the proliferation of these tumors stay very, very low. And the other point you need to be careful is that many different distinct tumor entities can have PHAT-like features, like schwannoma, for example. And this, of course, has one hand in this schwannoma. Meningioma, look at this. Isn't it beautiful? Solative fibrous tumor is another entity. These are all lesions that may have, you know, different degree of aggressiveness. So going towards the last part of my talk, I just start thinking, of course, we could stay here years and years and discussing how to be most often wrong. But for example, I have things that now I learn are particularly wrong. For example, when we want to diagnose myxoid liposarcoma in retroperitoneum, as you may believe, I've seen a substantial number of myxoid liposarcoma and retroperitoneal sarcomas. In my life, and I turned 60 a few months ago, I only have one myxoid liposarcoma that we believe arose primarily in the retroperitoneum. And by the way, it was the sister of a colleague. So myxoid liposarcoma can metastasize to retroperitoneum, but almost never occurs as a primary. So when you have a myxoid sarcoma in the retroperitoneum, and this happens almost every week to me, the correct diagnosis just around MDM2 will be the differentiated liposarcoma with mix of fibrosarcoma-like feature, or could be rarely myxoid SFT, or even more rarely, a mix of fibrosarcoma-like pleomorphic liposarcoma. Does it make a difference? Of course it does make a difference, because if it is the LPS, our surgeons, our good friend surgeon will go through multivisceral resection. If it is metastatic myxoid liposarcoma, you have to give chemo or radiotherapy or trabectedin or ribolin, whatever, but not definitely try to do a multivisceral resection on the poor thing. So this is a myxoid liposarcoma with a typical plexiform vascularization, you know, the crow's feet, the chicken wire, and so on, the small lipoblasts. Of course, as you know, cellularity is the parameter that we currently use to try to predict tendency to systemic spread. But look at this. This is the diff-like, the differentiated liposarcoma, MFS-like, mixed fibrosarcoma-like. You may even have some plexiform vascular pattern, but then you have cytologic atypia that you don't usually get into myxoid liposarcoma. And this is a pleomorphic liposarcoma. You can see here. Actually, on the biopsy, we call this myxofibrosarcoma. And then when we saw actually, this is a case of that we share with my friends in Rizzoli Institute, because this was part of the study of the Italian sarcoma group. So we did a diagnosis of myxofibrosarcoma on the biopsy, and then when we got the surgical specimen, we got these things here, and I say, oh, yeah, this is a mistake of mine. This is a pleomorphic liposarcoma with MFS-like features. Second point, if you want to be most often wrong, diagnose MPNST in the skin. I think now I'm getting hopeless. So every week we get spindle cell melanoma that for some reason get diagnosed MPNST. So MPNST, malignant peripheral nerve sheath tumor, almost never occur as a primary skin lesions. The only MPNST that need to be very superficial is epithelioid MPNST that, as you know, as you may remember, has two contrasting features to normal MPNST. It is HES1 diffusely HES1 positive and get loss up to 75% of the cases of anyone. So if you play with a small rule, then of course exception may occur, but you start thinking, okay, most HES1 positive spindle cell pleomorphic sarcoma in the skin or sarcoma in melanoma will be right 99.9% of the time. So you can accept to be wrong 0.1%, but not being wrong all the times. And this is epithelioid MPNST, the only one you can have. It is multinodular, actually looks a bit like melanoma because of vesicular nuclei, macronucleoli. But as most of the MPNSTs also tend to like blood vessels, you can see how it can surround blood vessels. You would like to jump into the blood vessel. And this is HES100. No classic MPNST will have this HES100 immunopositivity. And anyone, loss of anyone, this is a built-in control in blood vessels, is fantastic in improving you are dealing with your epithelioid MPNST. Of course, with the caveat that anyone can be lost in many things. Epithelial sarcoma, malignant rhabdoid tumor, atypical rhabdoid thoracic tumor, the small or the central nervous system, epithelial MPNST, some epithelial tumor, extraskeletal mixed chondrosarcoma, synovial sarcoma, and then also epithelial malignancy, and so on. Some undifferentiated neoplasm in the esophagus tend to have SMARCB1 deficiency. So again, it's not one single marker, but is one marker in the context of other markers, and most of all in the context of the clinical presentation and the morphology. And this is a sarcoma melanoma. Of course, it doesn't look like a garden variety melanoma, but you have to think about melanoma when you have this horrible thing staining so diffusely for HES100. And this is HES100 in this lesion. And Abasa gave me very recently pointed to this concept of undifferentiated melanoma, dead differentiated, which is at times a little bit abused, I think. But anyway, the relevance of this paper is just because they start, in a way, raising the issue of diagnosing melanoma when it doesn't really look like a melanoma, which is an issue that is being observed for years and years. I'm happy that somebody at the end decided to write a paper on this. Another way to be most often wrong. Myxofibrosarcoma never or almost never occurs in young. Very rarely is a deep-seated mass. So myxofibrosarcoma is always, 80% of the time, a multinodular lesion occurring in the superficial soft tissue of elderly patients. It's what you have. It's a low grade, if you wish, even here they start being a little bit more cellular and typical. You have, of course, nice morphology criteria. So the myxoid, of course, matrix, the nuclear tibia, the archiform blood vessels, they are not like the plexiform vessels of myxoid liposarcoma. They're different, it looks different. And of course, then you have transitions to these high-grade horrible lesion in which you start having this high-grade malignancy that we call high-grade myxofibrosarcoma. To diagnose myxoid liposarcoma and mass occurring in the head and neck, because most likely, or remember, usually patient in the third decade, mass in the thigh. 85% of the time, this is a clinical presentation of myxoid liposarcoma. Of course, you can mix a myxoid liposarcoma in the head and neck, but most of the time, you will have to deal with a spindle cell lipoma, nice tumor, very indolent, even with no genetic aberration, the only one who don't have genetic aberration, that for some reason decided to get through myxoid degeneration. What is the clue? The presence of the ropey collagen bundles, eosinophilic collagen bundles that you will never see in a myxoid liposarcoma. And of course, in a myxoid liposarcoma, you will have the plexiform vascularization that you don't get in myxoid spindle cell lipoma. If you want to be also wrong, as we mentioned already, diagnose PHAT in presence of high mitotic activity. Probably you're just misjudging a high-grade pleomorphic sarcoma with some PHAT features that we discussed. And then you can be wrong using immunohistochemistry extensively, because remember, this is one of the law of God. Immunohistochemistry is sensitive, not mine, oh God. Immunohistochemistry is sensitive, but not specific, with very, very, very few exceptions. So we should never rely upon single immunostains. We shouldn't equally not rely upon excessive number of immunostains. It just means that you need that morphology be your guide. When I get cases in consultation and we have, 45 immunostains, and maybe it was a small biopsy, so there is no leftover to do the single one irrelevant, then of course, you get into an even major challenge. So just use the immuno that you need. I can give you really a number, but the more immuno I do, the less I understand about the tumor. So most of the time, with 4, 5, or 6 immunos, I'm done with that. If my immuno get guided by morphologic observation. We have sometimes fixation issue, so we need to be careful. But we have some situation in which, so you need to trust what you're getting into when you do immuno, because maybe it's negative, but please, it should be negative. We should have internal control. Remember that when you see many cases from outside, the quality of the fixation may vary. So you have to adapt your protocols to what you get. That's why negative or positive control could be helpful in those diagnoses. But when you have immuno, some simple rules. Please don't make a diagnosis of Ewing sarcoma if CD99 is negative. You have going to the data that my friends at the study put together, a chance to be wrong, which is probably 99 plus 9999. I wouldn't do that. As it is diagnosed in PNST and spindle cell neoplasm that express diffusely S100, we just discussed this. And then, of course, please don't get offended, but Ki67 is not the way to go. I will tell you a small story. I can't show the picture because it's a case of 2 days ago. This is a colleague of ours. Actually, she left pathology a few years ago and then get a call from a friend in Milan saying, there is a colleague of ours that I would like you to look at his lesion in the nasal cavity. Because this woman was diagnosed as angiosarcoma of the nasal cavity. Well, I get the case. And we start looking with Martha, with my co-worker. I see, look, it's true, there was some cytologic atypia, but the patient went through, because she had epistaxis, she went through repeated cauterization of the lesion. Well, to cut the story short, that was an ulcerated hemangioma that it was called angiosarcoma. You want to know why? Because they did Ki67 and the Ki67 was high. Now, if you take a pyogenic granuloma and stain with Ki67, you will have 95%. But Ki67 doesn't make a benign thing as sarcoma. So unless you are not a neuroendocrine pathologist or a neuropathologist, please don't rely upon Ki67 when dealing with soft tissue lesion. even molecular genetics, if disconnected from morphology, can be a problem. I can tell you another small history, and this is why my mistake again. I got a case from another big place, and they asked me to run. At the time, it was one of, I jump on the GIST molecular characterization almost 20 years ago. So they asked me to do the genetics from GIST on this patient, but they didn't send me the surgical specimen. I was so stupid to run the GIST, the KIT and PDGFR alpha mutation, that of course was negative. And the patient progressed and the patient died, but not because it was a wild type GIST, just because we're using sarcoma. And I will tell you, this situation end up in illegal medical litigations that, for God's sake, didn't involve me. But since then, I will never anymore run a genetics without knowing what is in the patient, what is the disease. Another problem, consider technical issue. Now our friends in particular from the molecular genetics, now thank God, even the surgeons start to be fan of NGS, of extensive profiling and so on. Anyway, remember that these techniques are all quite complicated. If immunohistochemistry is complicated, molecular genetics is more complicated. So you need to have very solid, good quality in the lab. And my experience with GIST, for example, that most of the wild type GIST actually, which I'm very fond of because we have a line of research on that, actually most of the time represents a technical failure. Remember also that you need to pick up the best technology because, for example, fish may miss because gene rearrangements are chicory arrangements. So in this situation, currently, in particular for round cell sarcoma, maybe next generation sequencing or massive parallel sequence, target NGS actually is the way to go if you want to use those labels. And remember, if you have a sarcoma and you prove a rearrangement of EWS1, look at the many things that get actually EWS rearranged. So it can be simply this. So I just try to give examples, just examples. I think that expertise is the key, and I understand that defining expertise is almost impossible. I've been asked so many times, how do you define expertise in pathology? I have no idea. But I mean, the minimum criteria to get proper training, and I'm so grateful to the colleagues that helped me a lot in trying to form my current knowledge, but also you need to see the cases. But I can't say how many cases you need to see. When you have to deal with the sarcomas, you have to be aware of the mimics. That is so typical of our discipline. That's why mix of tissue and bone tumors so special. Because soft tissue tumor, and this is of course is also true for bone sarcoma, may not follow conventional criteria of malignancy. Most of people look at the chondroblastoma for the first time and think it's horrible and aggressive or a giant cell tumor bone. But we know that, of course, they are not as aggressive as other bone entities. So, of course, you need to know the entities. And, of course, when you deal with bone, you need also to, in contrast to what you need in soft tissue tumors, the knowledge of radiology of the imaging is crucial when you have to draw a conclusion on a given patient. But the most important rule that whatever the technique you're using, immunohistochemistry, genetics, FISH, Sanger sequencing, real-time PCR, next generation sequence, these must be driven by morphology. This is fundamental. Otherwise, you will be surprised. But if I ask you, do you think that the implementation of molecular genetics improve the quality of diagnosis in expert centers? You may say, oh, of course, yes, because now they have the answer. Well, the truth that there is a nice paper from the British sarcoma groups and the Royal Marsden, in which actually Cyril Fisher is one of the authors, in which they proved that actually the implementation of molecular genetics in the diagnostic of soft tissue tumors in non-expert center increase the rate of diagnostic inaccuracy. And this is quite obvious, just if you consider what I just told about the story of the Ewing sarcoma. So, of course, it is challenging. Of course, it's not at all easy. But, you know, my experience as a second opinionist is that if we help each other, if we talk to clinicians, if you take into considerations clinical history, and we rely upon morphology, then implementing immunohistochemistry, and when it's helpful, molecular genetics, then of course we can do a good job. And I think this is the end of my very long talk. I'm so sorry for having bothered you with so many slides. Now, I think I can interrupt the sharing. I can say hello to Francis, which I think probably is California at the moment. And I think we have some questions on the chat, which I'll try to answer. Oh, good.
Ask him.
John says, if mixed cell liposarcoma is in the retroperitoneum on the abdomen, look for a cold primer. Yes, of course, Gary. Thank you, Dr. Thal. Thank you. So then, Paul, if you have to quantify over 100% how much corresponds to the tumor morphology evaluation to make up a diagnosis in sarcoma seen by an expert pathology,
I'm just debating where I should be a pain in the ass.
I don't really know. So, you know, it's difficult to answer this. I wouldn't know. I can only tell you that the rule of 1/3 of inaccuracy is what I can see. Anyway, I'm happy to answer to any question you may like, or any comments more or less, because I don't think that end you need to ask questions, but maybe would like to make some comments.
Paolo, do you mind if I want to ask your insight with regards to AFX dermal sarcoma?
Yeah.
Do you think if you left an AFX alone, it becomes a dermal sarcoma?
I think, honestly, I think yes.
And if you leave a dermal sarcoma alone, it will be grow deep-seated and be something you would call UPS?
I basically agree with you. You know,
so let me just finish. Why not call an AFX a small superficial sarcoma that, because of its small size, superficial location, has an excellent prognosis, like a very small superficially invasive breast cancer or superficial melanoma? The terms don't change because they have an excellent prognosis.
No, I agree with you. You know, this is just historical thing. As
change
you
it.
Yeah, we can change.
You're 60 now. You can do that.
Oh, thank you. No, I agree with you. You know, I agree with you. I think at least genetically, they're exactly the same thing. One point in this superficial thing that they seem really to be UV related. So probably there is something in the genetics that makes them a little bit different. But I understand, but I agree with you. When they grow deep, it becomes a problem.
Okay. Thanks.
Any other questions or any other disagreement also?
Hi, Paolo. Buonasera.
Ciao, there is one question here actually. Fernando asked if the differentiated liposarcoma, is the differentiated liposarcoma a differential diagnosis of FST if having a STAT6 positive mass in the thigh? No, for two reasons. In the somatic soft tissue, the diff lipo is very, very rare compared to SFT. In the retroperitoneum, you may have the issue because you have SFT-like the diff lipo, but those SFT-like the diff lipo will be MDM2 plus STAT6 negative. So STAT6 is a very, very sensitive and loyal marker for solitary fibrous tumor. But you know, in the retroperitoneum, you can have the issue of differentiating those two things. Please, ciao, Heidi.
Hi, Paolo. For example, in the case of SFT in retroperitoneal tumors, what about those cases that are truly negative? There are 30% that can be negative, right? But it's 34, CD20, 34 positive. And then the recurrence is totally negative for CD34, obviously negative for STAT6, and then the only thing that you can do or you can put is the differentiated liposarcoma. That's an issue that I did have a few days ago with Dr. Dominguez, because the previous was actually diagnosis as SFT. So what do you do in those cases? Is like the trash, or what to do with those cases? Because your clinician is like what to do.
As I mentioned before, I mean, actually, my experience with STAT6 in combination with morphology is better than the 30% of cases which would be negative. It is true that SFT sometimes can have some MDM2 immunopositivity. Then it is one of the situations in which, if I am in doubt, in order to trust MDM2, you may decide to run a FISH or a quantitative PCR or a real-time PCR in order to see whether amplification is really there. Because, you know, in the retroperitoneum, I would say that the diff lipo would beat SFT 10-1. So, you know, if you have a pleomorphic or sphenoid neoplasm MDM2 positive in the retroperitoneum, I'm pretty confident I'm going to call this the diff lipo. It is true, though. We have situation, Alessandro Gronchi shared with me a couple of cases in which you would jury this is going to be the diff lipo, and MDM2 is not there. But you know, basically in no tumor we have, you know, 100% of anything. So
yeah, I know.
Them, you know, very few of them actually get, you know, invariably the same genetic observation. That's why morphology is so important. So in the end, we decide.
Yeah, the previously did look like, you know, when you have the recurrence and you see it, you go and get the previous. And we did CDK4 in both cases.
Yeah.
And the previous was negative. And this one was positive. So you're like, oh, so what it was actually? Or because,
you know, CDK4 point to the diff lipo. I just want to raise a point of caution, because CDK4 immuno tend to be a little bit, you know,
promiscuous.
A little bit. So you know, the joke I could make, if you want to have something positive, just stain for CDK4.
Yeah.
But if, for example, if you say intranodal myofibroblastoma for CDK4 is positive, and nobody knows why.
My fibroblastic too. Yeah, I know.
Nobody knows why, you know, because there is no amplification, no genetics that apparently get upregulated by a mechanism that we don't know yet. I mean, so another word on STAT6. STAT6 is a bit sensitive to fixation. So if you have a STAT6 which is negative, maybe, and it's not your case, I mean, maybe you can play a little bit with antigen retrieval, because sometimes not too much, because then you get everything STAT6 positive. Another possibility is try to run the molecular genetics for STAT6, NAB2. I mean, but you know, in the end, you have also to consider if it is a recurrence, if it is worth, you know, driving mad.
Yeah, and the clinicians send it like lipo. Yeah, you know, because everything about retroperitoneal is mostly like lipo. I know, but it was very strange to see the same tumor it was a consultation case, the previous one, but it was very, very different, the morphology. So the immunohistochemistry was very different. So the only thing that I can think about is that it wasn't the patient's tumor. I don't know, because it looks very different. But well, that actually can happen. But congratulations, it was amazing. I have too many aha moments because I have seen those fatal mistakes from a lot of places that comes to our hospital. But it was amazing, your presentation, really, truly.
Thank you, Heidi. I appreciate it. I think Nadia wanted to say something at the point, but we stopped her. We have been very naughty to our clinical colleagues.
I as an oncologist, I enjoyed much your lecture. I already knew that diagnosis was very difficult, but with all the examples you gave us, I am more comprehensive today. I mean, it's really tough to get a good diagnosis. And I think you spoke about many cases, many tricky cases in which diagnosis was really, really difficult. But I think for the message for the pathologists is also that there are really special difficult cases, but I think we should be always correct on the easy diagnosis, because it's also very common to have, as you commented before, to misdiagnose a GIST with a Ewing sarcoma. This cannot happen. I mean, there are entities in which arriving to a correct diagnosis, it's really difficult, but we have to keep on the basics in the sense that we cannot permit wrong diagnosis in the easy.
Yes, this is has to do with the organization of the health system in a way, because, you know, I see here in the group of people that join us together, many friends of mine, people we share cases with, and we discuss many times. They all know. I'm sure that most of the people here can easily handle even challenging cases. Sometimes, you know, cases are simply impossible nowadays. So I was sharing with Chris a situation in which I say, Chris, I don't know what it is. Please help me.
Yeah.
You reply back, I don't know either. I mean, so we simply know that sometimes cases are impossible. But as you mentioned, there are situations in which, you know, it is difficult to accept. It is difficult to accept. We have, even in my region, we have a situation in which there is one specific small place in which there is a surgeon who wants to perform bone biopsies. And, you know, most of the time we get this case with the most crazy diagnosis, you know, fracture callus that we call osteosarcomas, just to give you one example. And you see, this is a situation in which it is not a challenge. It's simply people have no idea what they're talking about.
That's what I mean.
Yeah.
The classic retroperitoneal osteosarcoma, that is will deep lipo with osteogenic metaplastic differentiation, and you receive the patient and you say, come on, this cannot exist. I mean, these kind of things have to be avoided, in the sense that for some non-expert pathologists, all sarcoma can be very tricky and challenging, but for expert pathologists, I would say 10% of diagnoses are tricky, because in the other 80-90% of cases, you do it perfectly. And this makes such a big difference in the clinic. So we have to highlight that, I think.
And you know what? I also thank also to SELNET, this type of relationships we are building across the world. I mean, actually, I'm changing a little bit my mind regarding the value of educational activity, because in the end, you know, colleagues who want to specialize in soft tissue, I think have an inner drive that they know that it's going to be difficult. They know perfectly it's going to be difficult. But they also have, I think, the brightness to learn. They're eager to learn. So I have to admit that when we meet, when we do slide seminars and so on, I can tell you, I mean, people are really good in making diagnoses. And the cases they show are really challenging. So we simply I think, create and implement spaces for sharing cases. So now, you know, with digital pathology, all these, you know, possibility is much easier than it was like 10 or 20 years ago, in which digital pathology was not existing. So it is a quick way to solve easy cases. For example, of course, you know, if it is a crazy round cell sarcoma, you need NGS, period. But the stump of the uterus, you only need the slide, the H&E slide. There is no molecular genetics. There's no, you know, immunohistochemistry that can help you. It's just a matter of criteria and to put together some information. So we can easily do using those digital tools, which is so effective now.
Yeah, and with SELNET, we are trying to find any kind of solution to implement these kind of discussions between you, because some of the SELNET centers have also already access to digital pathology.
Yeah, right.
Let's see if we get any kind of solution to make this possible, because this would be great.
But I'll tell you, in particular, SELNET was born because we wanted to, you know, in a way, get a conjunction with that Central and Latin America. I'll tell you, all the times I went there, I remember my trips to Brazil, to Panama, to many other places in South America. The quality of the pathologist was amazing. Yeah. Was amazing. And when all the time I get back to my place and say, look at my residence, there are people there which don't have many times the resources we have, and that make far better diagnosis than we can do. So I think it's very mutual. So I learn a lot from colleagues all around the world, and I really admire them for what they could do. Sometimes, you know, not having access to the most sophisticated molecular genetics, and they do a great job. So I'm quite optimistic. You know, I think SELNET is doing a great job, by the way.
This was also the comment of Dr. Viloria Gonzalez on the chat. This colleague is from Costa Rica and say that in our country, we count with several genetic tests, but our battery is limited. So we rely deeply in morphology and immunohistochemistry. That's it. It happens in clinic also. There are many places in which doctors do not touch their patients, do not explore the patients, just see the CT scans or the PETs. If you miss the clinical signs and the anamnesis of the patient, you miss much of the information. So it's the same in pathology. You have to keep on the basics. Okay.
All right. I think we ran out of time, Nadia.
I think so. I would like to take this opportunity to introduce our new project manager with this.
Wonderful.
Here with me, Alvaro.
Hi.
So you will start to receive mails from Alvaro in the next weeks. Okay. So yes, I think this was the last educational pathology webinar for this year, but I think we have to set up a new program for 2022 because it has been very successful, especially this last one. We had more than 60, I think I saw 63 connected people, and a special thanks to the Miami team because all the specialists were connected, oncologists, surgical oncologists, pathologists, they were all here. So thank you very much to all of you. And
it was also nice to see, you know, I couldn't meet Andrew since 2 years now because of the COVID. Yeah. Hopefully next March, we're going to have a reunion in Los Angeles for the US capital that appears to be in person. So hopefully also our trip to Peru will be paid next year.
Yeah, I think we have to start to select dates. And I think we can make it a reality finally after 3 attempts. So let's see. So I would like you to switch on your cameras to take the classic photo, if you can. Well, I have here 16 people, but I think there are more. All right. Just one. Perfect. So thank you very much for attending. I would like to remind you that the 10th of November, within the CETOS meeting, we have a special SELNET meeting. I think it's going to be great. We have 3 great speakers, key opinion leaders, so do not miss the opportunity. We have already circulated the link. We will send reminders. For European partners, it's a bit late because it's 9:30 p.m., but I think we can join with a beer or something to make it more easy. Okay, thank you very much. Thank you, Paolo, because today it was an exceptional lecture. I really enjoyed it.
Thank you so much.
You will find the video within the web in the next days. Okay.
Wonderful. Thank you. Ciao, everybody.